Good morning, everyone, and welcome to just another TIRO by MD's multidisciplinary seminar. It's truly my pleasure to have all of you with us here today. This session is particularly meaningful to me, as we'll be discussing a topic that is both highly relevant and very close to my heart: how to adopt international guidelines in resource-limited settings. Today, we're honored to welcome an outstanding leader in thyroid cancer, Dr. Fabiàn Pitoia from Argentina. Dr. Pitoia is chief of the thyroid section at the Hospital de Clínicas in San José San Martín at the University of Buenos Aires. Former president of the Latin American Thyroid Society and a globally recognized expert with more than 300 publications and lectures worldwide. His work has profoundly shaped how we understand and manage thyroid cancer across different settings. And we're equally fortunate to have an exceptional panel of discussants today, colleagues that I am proud to call not only collaborators, but friends. Dr. Nicole Iñiguez-Ariza, an oncologic endocrinologist based in Mexico City, who brings a unique and powerful perspective to her work caring for patients in advanced thyroid cancer cases across diverse socioeconomic backgrounds, while also contributing actively to clinical research. Dr. Juan Pablo Dueñas from Colombia, an accomplished endocrine surgeon, an international leader in thyroid surgery and minimally invasive thyroid techniques, whose work continues to advance surgical innovations across Latin America. Together, this group represents some of the most thoughtful and impactful voices in our region. With that, it is my great honor to introduce to you Dr. Fabiàn Pitoia. Fabiàn, the floor is yours.
Thank you very much for the invitation. Okay, so we are going to speak about how we adapt international guidelines to resource-limited countries. And I have no conflicts of interest for this presentation. And I'm mainly focusing on two diseases: differentiated thyroid cancer and aplastic thyroid cancer. The last one with a big picture about the consensus we finished writing from the Latin American Thyroid Society, and it is going to be published very soon. So I would like to start with this phrase, which is from Jerry Ganswolski. He is from Argentina. He is a physicist and an innovation speaker. And it applies very much to how I see thyroid cancer, or how I have been living the evolution of this disease during these 25 years I've been dedicated to this disease. And it's like that throughout life, I keep collecting pieces of a puzzle I still cannot see. It's sometimes we put a piece of the puzzle in some place, and then we need to remove from there and put somewhere else. And this is constantly happening in thyroid cancer, and it continue happening. So if we think what happened during the last 30, 40 years, where we try to classify patients according mainly to stages, mainly to the TNM stages, and we did the same treatment for every single patient regarding the stage. And we had different frequencies of recurrence rates during follow-up. We didn't understand exactly what's going on. We were doing the same, but we had different recurrence rate. And it was not until the end of 2000 where we had this difference because of the inputs of Michael Tuttle showing that the risk of recurrence is something completely different to the risk of mortality. And it helps to predict the response to treatment. It helps to predict the frequency of structural incomplete response or excellent response to treatment. And again, then we understood that the response to treatment helps a lot to define how our patient is going to do during the long-term follow-up. So we need to put these puzzles all together: the pre-surgical evaluation, the risk of recurrent response to treatment, and then if we are going remnant ablation and then follow-up, to have the complete puzzle of these patients. But this is not always possible in Latin America and some other resource-limited countries, where many parts of these puzzles are missing, And sometimes one of the most important is the pathological report that is sometimes missing and sometimes very difficult to find. And we live that every single day with many patients in our hospital, mainly when we talk about public hospitals. So that was why last year, we gathered together a group of physicians we were called by the United Nations, by the International Atomic Energy Agency, and we gathered together to produce a document that could be adapted for these regions where we do not have all the information, where we do not have all the resources, and how we can move adapting international guidelines. And we are also writing now our Argentine Inter-Society Consensus for the Management of Differentiated Thyroid Cancer. It is going to be published mid-2026. So starting with the pre-surgical evaluation, we consider something that it's very frequent that we see in the public hospital. Although if you are in the private setting, we can do active surveillance with no problem because we have our ultrasonographyist, our patient that is very adherent for the follow-up. It is not always the case when we have patients in the public system. And we have to be very careful. Although the patient is a candidate for active surveillance, we sometimes cannot assure that the patient will return to the consultation. This is something that sometimes we have to guess. Another important thing that happens to us, and mainly in Argentina, is that we have different health insurances that can be seen in our hospital, but the studies cannot be done in our hospitals. So the study is done somewhere else, and we receive the ultrasonography or the information of the ultrasonography with no images or a few images, and where we cannot see clearly the thyroid nodule that is going to be a follow-up or is being followed up. So this needs to be taken into account when we consider active surveillance in the public systems, and it's very difficult to implement active surveillance in patients also when the social cultural level is low and the patient cannot understand exactly what we are meaning with the active surveillance. So this is something we also live very frequently in our public system. According to surgical management, we did not make many changes to the American Thyroid Association 2025 guidelines. It is lobectomy for most patients with low risk or suspected low risk thyroid cancer. But we made a consideration because a number of patients in low resource country will be operated with surgeons that has not enough expertise. Although, of course, we prefer that all patients are operated on by head and neck surgeons and with a high expertise of high volume. This is not always the case in our region, and sometimes we need to be careful if this patient is going to be harmed because we are planning a total thyroidectomy done by a not expert surgeon. Sometimes, preferably, we can choose lobectomy even in suspected intermediate or even high risk. Another thing that we need to consider in very low sociocultural level is that the patient may not come back to search for levothyroxine. And this is happening even in Argentina with low sociocultural level. The patient cannot pay for the levothyroxine. And sometimes we see patients after 2 years, he or she came back to our consultation with a TSH of 100, metastatic disease, and the patient is not receiving levothyroxine because he cannot buy levothyroxine. So this is something that sometimes is very difficult to explain when we talk about the gold standard, the guideline from the American Thyroid Association, and what we see every day in our public hospitals. Another important issue is the risk of recurrence in limited resource country. We know that this depends mainly on the pathologist, and of course, the pathologists have to be a specialist in thyroid cancer to define many of the 1,000 things. Now we need to classify these patients according to the risk of recurrence, and we sometimes we do not have this expertise because the pathologist probably is dedicated to all diseases and also a bit of thyroid cancer. So we know that we have some guidelines, some risk of recurrence according to previous guidelines, 2009, 2015, that modified in 2009. And these guidelines were previously validated. And we have this new one that you have also seen here, the 2025 risk of recurrence classification, which is now estimated risk of recurrence. Until the moment, we do not have many papers showing that this is really true. This is according to retrospective studies showing that the risk of recurrence might fit into these low, intermediate, high risk of recurrence. But we know that the 2009, the 2015 were already validated in several cohorts around the world. And so we know this, we can still continue applying these guidelines when we do not have the full information of the pathological report. So what we consider is that we can use any of the systems. We already knew this. Well, we can use the 2009, we can use the 2015, we can use the 2025 probably because it has not been yet validated. But it can help us to decide initial therapeutic decisions. And I tell an example that what we usually see every day in our hospital. For example, we have this patient, female, 23 years old, she received a total thyroidectomy with a central neck dissection. And we have a papillary thyroid cancer in a written report saying that she has a 3.5 centimeter tumor with 5 or from 10 lymph nodes, and the diameter of the metastatic lesion is not informed. Vascular invasion is not informed. We know the patient tells us that she received 100 millicuries and she traveled 1,000 or 1,500 kilometers to know our opinion about her case. And the patient, of course, is not going back to look for the slides, the pathology slides for review. So here we need to guess probably where this patient is going to be. Of course, if we use 2009 classification, we will understand that the probability of the frequency of a structural incomplete response is a bit higher. And maybe this patient can go from a low risk, intermediate low, intermediate, or intermediate high risk of recurrence. So we have like a range of imagining how this patient is going to fit into these risk of recurrence. And what I usually try to teach to my residents is that we do not need to worry about the initial risk of recurrence. Do not become crazy with putting the patient in which exactly percentage of a recurrence rate is going to be our patient, because the static risk of recurrence has a lower explained variance proportion, and it means how is it going to fit the final result compared to the dynamic risk of recurrence, which it is usually much higher, between 60 to 80%. So what we wrote is that when initial recurrence risk stratification is not feasible or it is incomplete, we can use the response to treatment to guide our follow-up and our decisions. And this is very important because this we can do it at the moment the patient arrives in the hospital. We can have a thyroglobulin, a TG antibodies measurement, we have a thyroid profile, and also we can do an ultrasound. So we can tell the patient, well, we are into these responses to treatment, and these are the frequencies of a structural incomplete response we are expecting. Of course, if we know that the patient comes from a low risk, we know that and has an excellent response to treatment, the frequency of a structural incomplete response during follow-up will be very low, between 1% and 2%, and it might be increased to 10, 15% if the patient had an initial high risk of recurrence. But we can have a better idea of how is going to be our patient during a long-term follow-up according to the responses to treatment. Another situation is the new consideration of excellent response for low-risk patients with thyroglobulin less than 2.5 with negative antibodies and negative findings in images. And of course, this is something that needs to be validated. There is still insufficient data to consider this level as an excellent response in low-risk patient. We know that this recommendation was based on a systematic review and should be interpreted with caution. There is a recent paper that has been published by a Korean group showing a very nice study showing a number of more than 9,500 patients who received total thyroidectomy and no remnant ablation. A small, very small group, 5% of patients with intermediate risk of recurrence. Most of these patients were low risk of recurrence. And they measured thyroglobulin under levothyroxine replacement. And what they showed here is the recurrence-free survival, showing that with an undetectable thyroglobulin, the percentage of a structural incomplete response is almost zero, and it can be growing between 0.3 or 0.2 to 5, which it can be around 5%, and it can be even higher with thyroglobulin higher than 5 nanograms per ml. If we look at here the thresholds between 1 and 2.5, we can see that the 10-year cumulative percentage of a structural incomplete response can reach 4%. Of course, here we are mixing up a group of patients with intermediate risk of recurrence. In the paper, I could not find exactly if these patients who had the recurrent disease were those intermediate, but we usually use the dynamic risk even for intermediate risk of recurrence to decide remnant ablation. So I think that these thresholds should be taken with caution, and probably we can say that if we have an undetectable thyroglobulin, we can relax, take a caipirinha and relax. And then if we have a moving thyroglobulin up, probably we need to be a bit worried, look for the structural incomplete response, that it can be growing up to 7%. And of course, with the thyroglobulin more than 5, we need to close follow-up to see exactly how the patient is doing with the structural incomplete response. Going to the ablation, remnant ablation, we didn't have any different consideration regarding the American Thyroid Association new guideline, but we moved a step forward because this is not based on references, mainly sparse consensus. And so we decided to put that for those low or intermediate risk of recurrence, if you wait and you have an excellent response to treatment, probably there's no need to do any remnant ablation for these patients. Finally, regarding radioiodine refractory thyroid cancer, we know that the definition, the molecular testing, the moment to perform molecular testing, the indication of therapy is identical, but the difference in Latin America or low-resource countries is mainly the availability of molecular testing when you do it, the availability of multikinase inhibitors and selective TKIs. And we wrote a paper in 2024 regarding these differences in Latin America. And we know that there is a huge difference according to what it happens in the public system and what we see in the private system. And the regulatory approval of these drugs are also different among countries. So, for example, in Argentina, we can use sorafenib and lenvatinib in the public system. It's variable, the use of cabozantinib. The approval is very difficult for the public system in Argentina. But we know, for example, in Brazil, in the public system, sorafenib is available, but lenvatinib is really very, very difficult to prescribe in the public system. So you only have sorafenib for advanced radioiodine refractory progressive patients. And this means that probably you need to think about when you're going to start treatment. Regarding selected TKI, there is almost, I would say, very sure that in the public system it's very difficult to have reimbursed larotrectinib or selpercatinib. We even do not have selpercatinib registered in Argentina, so we need to import selpercatinib patient by patient, and it depends mainly because of the health insurance if it will accept or not doing this. So it means that it's very, very difficult for us to do selected TKI treatments. So we need to put a tiered treatment approach for these limited resource settings, where if we have a basic one, when we say, well, we only have sorafenib and we are going to use sorafenib as a first and only line treatment. And so you say, well, let's not start very early when you have a 1 or 2 lesion of 1 centimeter progressing more than 20%. That would be the classical indication. And you will say, well, let's wait until the moment when we need or when we can use this multikinase inhibitor and the only one we will have. And of course, in this group of patients, probably we will not have the access to molecular testing. So an enhanced one is probably what we have in Argentina. We can use some molecular testing. Probably BRAF can be done very frequently. An NGS panel will be very difficult to obtain, even in the private setting. And multikinase inhibitors can be used. So we usually prescribe lenvatinib as a first-line treatment. But of course, we all prefer to be in the maximal scenario where we can have NGS and we can use selected TKI, a first-line treatment. As we know, these are more potent drugs. To end my talk, I would like to show you just a big picture of anaplastic thyroid cancer management in Latin America. This is a consensus led by Dr. Califano in Argentina. There are participants of all around Latin America, from Brazil, Chile, Colombia, and also Argentina. And of course, the big picture has to do mainly with the delayed diagnosis of anaplastic thyroid cancer. We have performed a multicentric study in Argentina that is going to be published soon. This study showed that the median diagnostic delay was 3 months, with a range even higher, even 5 months for anaplastic thyroid cancer. And it had to do mainly with the methodology used for diagnosis in not referral centers, where fine needle aspiration was the most used, but the frequency of diagnosing with the fine needle aspiration was only 30% in this setting. So 3 months for anaplastic thyroid cancers is really, really a long time. So another important thing is that there is a fragmented care with no referral network, and we need to develop this in Latin America, because there might be a missed surgical treatment window when this patient arrives 4-5 months later with the progressive disease. Another important thing is the limited molecular testing access, and in our study, the access was possible only in almost 70% of patients, and the BRAF B600E was obtained after 7 days, in the median of 7 days, but you can see the range that is almost 30 days to obtain the BRAF. Another not very nice thing is that sometimes we have the BRAF, but we positive BRAF in an anaplastic thyroid cancer patient, but we do not have access to the drugs. So why we did BRAF if we are not going to be able to access the dabrafenib, trametinib? And it happened in almost 56% of our patients. Well, we had the BRAF and then we didn't have the opportunity to use the rafenib or trametinib because it was not reimbursed or covered by the health insurance. And so the median delay to start the rafenib or trametinib in Argentina was around 40 days with a range of almost 70 days. This is unacceptable for anaplastic thyroid cancer. We can also add the low experience in low volume centers and the rigid guidelines adoptions that makes that it is really poor real world implementation. So we need to adapt a lot of these recommendations to what we have and to what we can do. But of course, the thing we need to improve is the first part of the of this algorithm, that is that the patient arrives early for being treated. So as conclusions, I would like to say that in Latin America, the highest impact comes from pragmatic adaptation of international guidelines, using a tiered resource-based approach. The dynamic risk adapted management for me is one of the most important things in differentiated thyroid cancer. It helps a lot to overcome the lack of initial risk of recurrence in most patients in whom we cannot have this information. And for anaplastic thyroid cancer, is the key unmet need is the diagnosis treatment gap. We, of course, if we test and we do not have treatment, this is not useful. And of course, we need to create fast track pathways, referral networks, and centralized expertise in mainly for patients with anaplastic thyroid cancer. So I think that it's not just following the guidelines, but sometimes these international guidelines that are gold standard need some kind of adapters to be put in the local care with the available resources and trying to build, of course, real clinical pathways that work. Thank you very much.
Fabiàn, thank you a lot for this very insightful presentation. I want to thank you also for all of the work that you've done in advanced thyroid cancer, in active surveillance in Latin America. But most importantly, I want to thank you, Amanda La Greca and Mike Tuttle, for introducing that term, the broken chair in thyroid cancer. I think it is very important, and it's potentially the reason why this the webinar and TIRO itself was created is to and Juan Pablo and Nicole, please join us. It is probably the reason why we started this with the itch that the guidelines, the international guidelines, the biggest societies, they assume or they take for granted that people that are reading the guidelines will be able to follow the guidelines as they were written, and that is most often not the case. Most of the thyroid nodules and thyroid cancers in the world, like you mentioned earlier, are treated in the community setting. And 68% of thyroid cancer deaths occur in resource-limited scenarios. So it's definitely something that we should think about. It's definitely something that should raise an eyebrows and make us think that what the medical community sees as an indolent disease might not be the case in most countries, because even here, Fabiàn, Nicole, Juan Pablo, we sit in a privileged position within our community where we have the most available resources in our countries. But that is not the reality for the rest of the country, as I am sure it is not the reality for all the places, even in the United States, where we consider a resource-rich setting. So I want to start the conversation with screening. Dr. Mike Tuttle always, when I have heard him lecture on thyroid nodules and thyroid cancer, he says that staging a thyroid cancer patient begins with a diagnosis. Sometimes a patient that has a small nodule that might have not been identified without an ultrasound, the mere fact of doing an ultrasound, identifying a nodule, and potentially biopsying that nodule makes that person a cancer patient when he was not, maybe a couple of weeks prior to that event. So what does screening look like in your hands? How does Argentina look from the screening standpoint? Because this is how we will calculate the wave of patients that will come in to see Fabiàn Pitoia, or potentially all of the Argentine endocrinologists or physicians that do see thyroid nodules. Do you palpate? Do you do routine ultrasound? What is the picture in Argentina?
No. We from endocrinology, we do not propose to do, as you know, routine ultrasound, but we receive usually these patients with routine ultrasound performed by the clinician or the dermatologist, gynecologist, and we usually receive patients. Even in the public system, I would say that we do not have this advanced case that were not diagnosed early because the study was not performed. So this is it's so complex to explain exactly how I live my life, like it's separated into two worlds in the same day, because in the same day I go to the hospital and I see some things with some tools I can use and some other that I cannot. And in the same day, you see all the resources available at the same moment. So this situation is very, very, very demanding with the brain, where you have to adapt one moment in the morning to one thing and in the afternoon to another thing. So, but I would answering your question, I would say that most of patients arrive with an incidental diagnosis of thyroid cancer.
Nicole, I saw you smile a bit when you heard that Fabian has to switch hats in the morning and in the afternoon. What is the scenario here in Mexico? Tell us a little about of diagnosis of thyroid nodules.
Yeah, I was smiling because I have the same exact situation. I see two very different worlds. And yes, you do need to adapt. And also, family support is really, really important, especially in the care of advanced thyroid cancer. It really helps even in limited settings if you have that support. Sometimes they can get this, they do a really, really an effort to get a genetic testing even out of pocket. And so it varies between patients. We like the Dr. Pitoia said, we do not recommend screening, but we do see it a lot for hypothyroidism, or if they go to the gynecologist, they like to check also thyroid while they're doing ultrasound of the ovaries and things like that are just not recommended. I think we need to educate more our not endocrinologist colleagues to decrease this. But in the limited, in the uninsured population, we do not see that much of incidental findings as we do in the insured population. The presentation is usually palpation of a thyroid nodule or lymph nodes and things like that.
Pablo, how does the picture look in Colombia? I'm speaking to a different person, a person that is a surgeon, potentially not the first person that sees a thyroid nodule before it gets treated, and a person who is an expert with ultrasound and minimally invasive techniques that is changing the way that we think about looking for thyroid nodules. How does thyroid nodule identification and treatment look like in Colombia?
Okay, thank you very much, Camilo. Okay, the vast majority of the PTCs across the world are tumors less than 2 centimeters. Most of them doesn't have symptoms. It is impossible for palpation. So almost the majority of those patients have incidental findings during an ultrasound for other medical conditions. So the screening is not recommended, but we have to be prepared because this is the reality in Latin America and this is the reality worldwide. I think that decrease that number, it could be very impossible, and I think that this number will be increased with the next years because every single day radiologists perform neck ultrasounds for other conditions. So the number will be increased. I think that. As surgeon, and a physician that attend patients with PTCs, I think that most important is the education of physicians on ultrasound because this is our reality. So the next step and the cornerstone for the management of the PTC, low risk PTC, is a very good assessment of the neck on the ultrasound, and we need to be prepared for that. I don't think that we could decrease the number of ultrasounds of the neck in the future. So we need to prepare the physicians to take the correct decisions, mainly in the correct diagnosis of the patient for the correct extension of the surgery.
Fabian, do you do ultrasounds in your patients, or do you have them done by a sonographist close to you?
No, I always perform my own ultrasound on my patients since 10 years ago.
Fabian, what is the scenario with you?
In Argentina, most of the endocrinologists won't have an ultrasound in the office, and in our hospital, you need to send it to the radiologist. It is always done, I would say, 99% by the radiologist.
This is an interesting difference in practice, because here in Mexico, and Nicole, you can speak to this, we have a lot of ultrasounds that are done for diverse reasons, like you mentioned before. But there's a couple of imaging companies that have lowered the cost of ultrasound almost to zero, to try to have people come into their companies and have more tests done. And it brings a wave of ultrasounds that are poorly done, poorly reported, and potentially bring a lot of unnecessary diagnosis of thyroid nodules and doubts that have to have a remake of that ultrasound, which is a pain, because it is a financial burden both for the patients and for the system, and it fills the clinic with patients that potentially didn't need to be seen. And this is why I bring this picture to the topic, because the epidemiological paradox, the amount of people that we see is gonna be different in every place where we are evaluating thyroid nodules, based on how we are screening or identifying these nodules. The second concept that I wanted to mention was exactly the broken chair that Fabian and Amanda and Mike introduced in the past. And I think the way that we treat thyroid cancer patients depends vastly on the amount of trust that you have with your team. And that is the radiologist, the pathologist, the cytopathologist, to move forward. Do you have, I'm gonna move a little bit. Once that thyroid nodule has been identified and potentially we're planning treatment, for some small thyroid nodules, low risk thyroid nodules, active surveillance might be an option. Tell us about your experience with active surveillance in Argentina, Fabian. How does that look? Is it only an institution-driven effort? Is it something that is done widely across the social system in Argentina? Is it done always by the same sonographist? What is the picture of active surveillance?
Well, as I mentioned in my talk, it is very, very difficult to do it in the hospital setting. We have a number of patients from the hospital, but yesterday we saw a patient that came back after 3 years, and of course, luckily the thyroid nodule did not grow, but that makes us question if the patient really understood what we wanted to say. And of course, in a hospital, this is very difficult when you want to say, well, we are going to call every single patient that is into active surveillance. And at the same time, we are seeing patients with multikinase inhibitors, patients with anaplastic thyroid cancer. That is a whole day. I can see around 80 patients. Of course, I don't see the patient. The residents do the work, and then I coordinate the decisions with other doctors, with other medical from the staff, to decide what we are doing every time with these patients. So we see 80 to 100 patients each week, and it's very difficult when you want to say, well, we are going to call patient X to come back to see how the active surveillance is working. That is very, very difficult in the public system. In the private system, it's completely different. And what we have seen during the last 10 years, we published this last year, showing that there was no increase in the acceptance of active surveillance in Argentina in the private system. We had 25% of acceptance in 2014, and it was 30% in 2024, the acceptance of low-risk patients for active surveillance. So it didn't change. It didn't move out as it did in Japan, for example, in 10 years after the beginning of active surveillance. And I think it has to do with our population, which is usually maximalist. And if you say the word cancer, probably won't accept to move to active surveillance. Mainly those patients who accept after surveillance are those patients who really search for active surveillance.
I was actually just going to say that it's very cultural. Nicole, how do you find the cultural problem of active surveillance in Mexico? I feel like, just as Fabian said, I have a thyroid nodule. You called it cancer. Take it out yesterday. No?
Yeah, I do think there are cultural differences. And the social cultural status within our own population changes the acceptance rate. The decision aid that Mayo Clinic and Brito have adapted and incorporated can help, but it takes time. In the private practice, it's easier. In the public system, because of this socioeconomic differences, it is more difficult to practice the active surveillance. We currently have a trial on that, and we haven't been able to include many patients. We have and we do need to do a dedicated time for this, so they can really understand, trying not to bias the decision. And also we are just getting cancers that are not, the location and other things are not candidates. So I would think it's still, it's an option, but it's not widely used.
Juan Pablo, moving a little bit forward, I know you are a person that has pushed the field of ablative techniques forward, and ablative techniques in Latin America, I feel like, have been accepted a little bit better than active surveillance because the patients feel that they're doing something to their nodules. How does that look in Colombia?
Actually, I think that the first barrier for the active surveillance is not the patient, it's the physician. Because I think that most of the physicians or surgeons in Colombia or even in Latin America doesn't like active surveillance. So many patients doesn't receive that option in the first consultant. Second, in the public system, most of the patients with thyroid cancer goes first to the surgeon than the endocrinologist. So those patients doesn't have the opportunity to receive the management like active surveillance. The ideal patient for active surveillance is the ideal patient for thermal ablation in low-risk PTC, mainly those patients with less than 1 centimeter. So in the last 2 or 3 years, many patients came here to the office because they want thermal ablation for a low-risk PTC. So the information, the patients have the information right now. This is available in almost all countries in Latin America. So this is an option. Even the new guidelines of the ATI provides the same level of evidence for thermal ablation than active surveillance. So this is a new option for the patients that doesn't want active surveillance, or even if those patients have a contraindication for surgery or something like that. But the main reason today is the patient have the information about the thermal ablation and the good results of these technologies for better results or good results in the future. So depends on the health system in the setting, if the private or public, in our country, in the public system, we don't have yet thermal ablation for risk papillary thyroid cancers. But those patients, when arrives to the inside of the public health system, most of them, the first consultant with the diagnosis is with a surgeon, and most of those patients, even with micropapillary thyroid cancer, goes to surgery. So we need to try to do something in this setting, but it's very difficult because we have to manage many barriers for the patients, and the first barrier is the first physician that attend the patient.
Totally, I agree with you. I think that you're totally on the same train of thought that I am. I feel I wanted you to speak to about thermal ablation because I feel, although that conceptually doing thyroid ablation on a micropapillary thyroid carcinoma, it feels like you're doing something, and it is that feeling that it is a little better, quote unquote, than active surveillance. However, we have to take into account that after you do a thermal ablation, you don't just do the thermal ablation and discharge the patient. You actually go through a protocol of, quote unquote, active surveillance. You still have to follow the patient to evaluate the risk, the reduction rates that the nodule might have had. So it's not a process that is free of the need of resources, both economical and human. And I don't know if you have any comments about that.
But Camilo, every single patient with thyroid cancer requires long life follow-up.
That is correct. That is correct. And that was actually my next comment.
No, I can comment something because you have the view probably biased because you do that. And probably your perception, but it's not what I usually see with my patients with active surveillance. So we have more than 150 patients on active surveillance. Yes. And I can assure you that a big number of these patients wouldn't move. These are really, truly minimalist patients. They don't even want a radiofrequency ablation. So the patient who really knows about the three options, active surveillance, radiofrequency ablation or thermal ablation, and surgery, they are really prone to continue with doing nothing and just nothing and taking all the homeopathic things they think can help. They are very, very happy with the decision. And of course, there will be a group of patients that will be, they are happier saying, well, I prefer to do something. I say that is in the middle of maximalist and minimalist patients. Let's do something, but not something very invasive. And these are the patients. But one of the limitations we have, and it's really that this patient has to pay for the procedure, for the needle, for everything in Argentina. So you have a conflict there because you can say, yes, you can do that, but you have to pay the procedure and the surgeon because there's no health insurance that is reimbursing this in Argentina. So this is another limitation that we need to consider.
No, Fabian, I absolutely agree with you. As I told before, many patients across Latin America doesn't receive the three options of management.
Okay.
This is my point. Most of the patient doesn't receive the three options.
Yeah, I know. I agree that all the options you have to give your patient, even in the hospital setting. We explain the patient, this is and there, but of course the patient decides what he can do. And it's sometimes very, not for active surveillance or radiofrequency ablation, because that won't change the prognosis. But as Nicole said before, the use of a panel paid out of the pocket of the family, that sometimes is $2,000 or $3,000 or $150, $500. That is a lot of money for a family that had to put together all that money in order to have a test, and we don't know how much we can do with that test. And of course, we offer this our patient. And ideally, it would be fantastic that we can have this test paid by the government, by the public system, but it doesn't happen.
Doesn't happen.
It doesn't happen, and it's something that definitely should be included in the consent of what we should do with a patient next. Nicole, do you consent them for the three treatment options? You might have a little different scenario because you're mostly looked for advanced thyroid disease, but tell us what does this decision look like in your hands?
Yeah, exactly. I do see mostly advanced in the public system, but I do see with fellows and everything the low risk. I do give the three options usually in my insured populations, and we try to also do it in the public system, but we basically do inform or active surveillance or surgery, and that's what we're doing.
And the decision, moving a little bit away from the subcentimeter thyroid nodule or thyroid carcinoma, there are different options of treatment, and the treatment options or the extent of the surgical decision also depends on how safe you feel. I mean, a surgery potentially in your hands, Juan Pablo, might be really safe, but potentially that patient treated out in the community in a rural place in Colombia might not have the same privilege or opportunity to do, for example, laryngeal nerve monitoring during the surgery, or have the expertise like Fabiàn was mentioning before. How do you go about choosing what type of surgery you do in your patients, and what is the state right now in your country, Colombia and Argentina and Mexico, as of what is happening? Are people being treated with total thyroidectomies as a one-size-fits-all kind of treatment? Are people moving towards lobectomy, subtotal thyroidectomies to be on the safe side? What is happening in your scenarios? Juan Pablo.
Okay, I start to perform lobectomies for low-risk PTCs since 2015, and the results are very nice, are very good for the patients and for me as surgeon, because the rate of complications is very low. A lobectomy is in a surgery that I perform in an ambulatory setting with very low risk of nerve damage, less than transient lesion, less than 2%. I always use nerve monitoring in all my surgeries, and most important than the recurrent laryngeal nerve lesion is that the probability of permanent hypoparathyroidism in those patients is zero, because with lobectomy it's impossible. What is the problem? The problem is more than 90% of the thyroidectomies for thyroid cancer or thyroid surgeries across the world are performed by low volume surgeons. And it could increase the risk of the surgery in more than 5 to 10 times. And the other problem is, even for high volume surgeons across the world and in Colombia, patients with a 2 centimeters tumor underwent total thyroidectomy. So we need to put in the mind of the surgeons that the best initial approach for the patients with low risk papillary thyroid cancer is the lobectomy. This is a very difficult issue because I saw many surgeons, high volume surgeons, perform total thyroidectomies for the patient with the risk of permanent hypoparathyroidism. This is a very bad situation for the patients. And the decision of the extent of the thyroidectomy depends on the features on ultrasound. So we need to encourage the surgeons to perform their own ultrasounds, and we need to encourage surgeons in perform more lobectomies than total thyroidectomies. But this is the reality across the world and in Latin America. A lot of total thyroidectomies that the patient doesn't require.
What do you think, Fabiàn?
Well, when we published our first active surveillance, 75% of patients chose surgery and 98% of these patients underwent total thyroidectomy. So we know that at that time it was the the chosen surgery. Now probably it moved a bit to lobectomy, but it has a resistance a lot to move with that lobectomy. Not in our hospital, not in referral center, but I mean in the community. It usually continue being, and our percentage of hypopara was really, really high, 5% for a microcarcinoma that did not accept active surveillance. So this is really high.
Nicole, two questions. First, what is the scenario in Mexico with the extent of surgery selection? And secondly, I'm going to have you speak just a couple of seconds, if you may, about the scenario of advanced thyroid cancer and anaplastic. Fabian was mentioning before that in their patients, there's a delay of, I don't know, Fabian, you said 3 to 4 months.
For the diagnosis.
How does that look like in our Mexican world?
Okay, yes. Yeah, we are, about the extent of surgery, we are offering thyroidectomy or lobectomy. But in most centers, I would think toral thyroidectomy is being done more frequently than lobectomy. We'll still need to work on that to decrease the number of toral thyroidectomy when a low risk thyroid cancer could be treated with a hemithyroidectomy. Regarding the advanced thyroid cancer care, it has switched a lot in the last years in Mexico, particularly in the institution that I work for the uninsured population. We are having access to the selective KIs and the MKIs. We do have access to lenvatinib now. The selective KI we have access sometimes, others not, but the system is not consistent. We are having access with BRAF, like from 1 month to now, which even though we have the drugs, then we don't have the BRAF. So we are just struggling to provide a consistent, high quality care for this patient. And we just need to adapt to what we have. So if we have the test, we can offer this newer drugs. If we're not, we just have to go with the for example, ATC cytotoxic chemotherapy, and we cannot even offer these newer drugs if we do not have the BRAF assessment. But I think we have moved forward a bit. But the thing is that we don't know for how long. We may have some months these drugs available, and then we just stop having them, and they just cannot buy it out of pocket, and it's gonna progress. So it's. I think we still need to work a lot on improving the care for our patients and having support for thyroid cancer, advanced thyroid cancer patients, and coverage by our government, which we don't have it consistently right now.
The undifferentiated and advanced thyroid cancer problem is one of diagnosis, and second one, as Fabian mentioned, you do a mutation analysis. You might have a BRAF mutation or you name it, and then a couple of months later, that mutation might have changed, and the treatment thus needs to be progressed. This calls for additional workup, doing molecular diagnosis. What does that look like in Argentina? How are you doing molecular diagnosis? Do you do NGS? Do you do in-house kind of?
We can use sponsored, laboratory-sponsored BRAF testing, and then forget of using, for example, immunotherapy for anaplastic thyroid cancer. Forget it. We can use sometimes dabrafenib trametinib for BRAF positive, but pembrolizumab is seldomly approved. I had never had a patient who could do pembro even in the private.
Pablo, is this any different in Colombia? Or do you have these tests, these drugs available for the majority? I mean, not for your own patients in private, but maybe like in the public system.
I think this is the same problem for all Latin America. The access to molecular testing is very poor because it's too expensive. And this is the reason because unfortunately, the patient doesn't have the opportunity of the resources to get a molecular testing. I think it is matter of money because that molecular testing is not covered by the public or private system even. So it's very difficult for us.
It is very difficult. So as we have been mentioning in these past couple of minutes, that the idea of thyroid cancer needs to change. The Latin America or the under served community needs to come together to create adapted guidelines to better serve our patients. I wish we had like 3 or 4 more hours to speak to this. It is a big topic. There's a lot to talk about. I cannot thank you all enough for being here this morning. Fabian, thank you for your work, for your presentation. Nicole, Juan Pablo, thank you for being here and bringing this very, very your insights to the presentation. And I want to invite everyone to come back next week for just another presentation in Thyroid by MDs. We're gonna bother Dr. Iñiguez again next week for being a discussant to Dr. Sarah Hamidi, who will be presenting adjuvant pembrolizumab after upfront multimodal therapy for advanced thyroid cancer. So I want to thank everybody. Please stay safe, have a wonderful weekend, and we'll see you soon.